MSK hand muscles. All right, so what you need to know about the hand muscles is that the thenar portion is going to be done by the median nerve, which is just the thumb, and then the hypothenar, which is just the pinky, is going to be done by the ulnar nerve. They're going to do the same thing. They're going to do the oath actions: oppose, abduct, and flex. Okay, and so that's what you need to know. For the dorsal interossei, you have the ulnar nerve doing both the interossei muscles. For both dorsal and for palmar, remember dab and pad. So dorsal interossei do abduction, palmar interossei do the adduction. Okay, so dab and pad. All right, very straightforward. And then the lumbricals, first and second is going to be the median, and then the third and fourth is going to be the ulnar. Okay, and the lumbricals, the action that I remember the lumbricals do is that they make your hand into an L. Okay, so read up on what the actions of the lumbricals do, and then make all of your fingers do it, and then you'll see that your hand kind of looks like an L. Okay. Next is distortion of the hand. We already discussed this, right? So we have the ulnar claw versus the hand of benediction, the median claw. And so all of these aren't too high yield because we already discussed what's going on. If you have an inability, for example, the ulnar claw, look at what the presentation looks like. You have an inability to extending the fingers, okay? So you can't extend the fingers of the ulnar fingers, right? So your pinky and your ring finger. You can't extend them, and that's due to an ulnar nerve damage, right? Now, on the opposite side, although it looks the same, this is the hand of benediction, but what you can't do is you can't make a fist with the three median nerves fingers, which is your thumb, your pointer finger, and your middle finger, right? And so that's a median nerve damage. The median claw is the same thing, median nerve damage as well. And so all of this is just pretty much straightforward for the distortion of the hands. Next is going to be the actions of the hip muscles. What they want you to know, honestly, it's so annoying, but they kind of want you to know about each of these actions and what does what. So first is the adductors. The adductors to me are the easiest because all of them start with adductor. So adductor magnus, adductor longus, and adductor brevis. All are going to adduct the hips, okay, the adductors. That's not something that they're going to really quiz you on, but just thought I should throw that out there. Next is the abductors, things that actually, push the hip out, okay? It's something that actually abducts the hip. What you need to know is the gluteus medius and the gluteus minimus, okay? So very straightforward. The gluteus medius and minimus are going to do abduction, okay? And while on the topic, they're also going to do internal rotation. So you've knocked out two of them, pretty much three. So adductors, we don't have to worry too much about because it's in the name. So abductors and internal rotation are going to go together, and they both have the gluteus medius and the gluteus minimus together, causing those, doing those actions of the hip. So remember that. But an additional internal rotation muscle is the tensor fasciae lata. So keep that in mind. Remember that as well. So we have abduction and internal rotation with the medius and minimus, and then internal rotation alone also has tensor fasciae lata. Next, we'll talk about the extensors. The extensors are going to be the gluteus maximus, the key one, gluteus maximus, okay, along with your hamstring muscles, right? And that's easy to remember. Gluteus maximus and then your hamstrings. You obviously know that your hamstrings are going to do extension of the hip muscles, but you just have to remember what they were. They're semitendinosus, semimembranosus, and the biceps femoris, the long head of the biceps femoris. That's your hamstrings, all right? Your flexors is going to be your iliopsoas and your rectus femoris. The rectus femoris is probably the highest yield one, all right? And then lastly, the external rotation is going to be your iliopsoas, your gluteus maximus, and your piriformis. All right. Now there's some things that help me remember. The maximus does the extra stuff. So maximus has an X in it compared to your medius and your minimus who do not have an X in it. That tells me that it does the extra stuff. And what does that mean? It does the extensors and it does the external rotation. So if you see extensor and external rotation, then that means that it could be gluteus maximus. Gluteus maximus does those two actions. Okay. Your medius and minimus does the abduction as well as your internal rotation. All right. Don't forget tensor fasciae lata, as well as the rectus femoris. Rectus femoris does flexors, tensor fasciae lata does internal rotation. All right. Now, lastly is our knee exam. Knee exam is very straightforward, easy. Okay. What you need to know is the anterior drawer test. Whenever you see anterior drawer test and it's positive, boom, ACL tear, right? And so what that is that you sit on the patient's foot and you pull the tibia forward. You pull the foot forward in comparison to the thigh. So you pull the tibia forward or anteriorly in comparison to the femur. And honestly, if it moves, if it shifts forward, then it's anterior drawer test, ACL injury, boom. Posterior drawer test, same thing, but opposite, and it's going to be PCL injury. So you're going to be bending the knee, same thing, and then we're going to push the tibia posteriorly. Okay, and if it slips, it's posterior drawer test positivity, and it's PCL injury. Valgus stress test versus varus stress test. So valgus stress test is going to be abnormal passive abduction, okay, of the knee, right? So you put in lateral force, And so you have like a space in the medial area of the knee that starts to widen, and that tells you that's an MCL injury. Varus is opposite. You're going to have an LCL injury when varus stress test is positive, okay? Right? And this is going to be lateral space widening of the tibia when you add medial force, okay? So last thing I would say about the knee exam, which isn't on here, is the patellar fracture. Whenever you have a patellar fracture, the patient's going to be cannot extend their knee against gravity. So you're going to have their patient lift their knee up or lift their leg up, and you're going to say, okay, extend your leg while it's in air. Okay, so everyone do that right now. Lift your leg up while you're sitting down in the sitting position, and then extend your knee. You're all able to do it. If you're not able to do it, well, guess what? You have a patellar fracture. Okay, so cannot extend knee against gravity is a high yield association for patellar fracture. All right, so this is kind of our hand muscles, our hip muscles, and the knee exam.